So please start your session.
थँक यू सर चालू करतो.
Oh,
Good afternoon, doctors. Welcome to this webinar on role of Oseltamivir in flu management. Doctor, this program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Hetero Healthcare is the largest closely held pharmaceutical company in India. We are among the largest manufacturers of ARV, APIs, and FDFs in the world, and we have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneer in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of pharma excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management, we have got Dr. Pramod Zog sir with us. Welcome, Dr. Pramod Zog. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. With this brief introduction, I hand over the section to Dr. Pramod Zog. Over to you, sir. I'll stop sharing my slides.
yes. Thank you. I will just start sharing my slides.
Yes, sir.
Are my slides visible?
Yes, sir. They are.
Okay, I will just make it in full screen. Yes.
Yes. Yes.
I hope I am audible. Yeah. Thank
Absolutely,
you.
sir. Perfect.
Thank you. Thank you. Thank you. So, my dear friends, today we will be discussing the use of oseltamivir in flu management. This is a very important topic, and it's the important approach to the management of influenza. And you can see that I have put up my name as the IAP presidential strain of 2016 because I just want you to understand that the nomenclature of influenza is dependent on the place where it originates and the year when it is originated and the strain. So one can remember that every year the strains of influenza, they show a bit of a variation, which is a minor variation, also known as a drift. I will tell you a little more about it during the course, and why I've written it as the presidential strain, because in IAP also the president changes every year. Okay, so we have to understand that the influenza virus, which is an RNA virus, it will always show little change. I call these RNA viruses as naughty viruses because they are known to change their structure. And these are the COVID-19 virus, the RSV virus, influenza virus. So they change every year, and we have to be very careful about it. Okay, and I'm sure in different parts of our country, monsoon is in full swing, and the illnesses like RSV, that is respiratory syncytial virus, and influenza, they are in full swing in different parts. Okay, of course, mosquito-borne illnesses like dengue are also being observed by our colleagues. However, when it comes to viral respiratory tract infections, one has to be very alert because gone are the days when we used to think that the condition is viral, and then we used to tell the parents that don't worry, it will take its own course of 3 to 5 days and the child will settle. But now we have realized that there is something like a cytokine storm which can come up after 5 days, 6 days, 7 days, and then a disease which appears simple to begin with, can get complicated after 5 or 6 or 7 days. And that's why we have to be very careful. What has happened is, after COVID, quite a few children and even adults, they did not have the immunity against certain types of viruses. So, in the post COVID period, we started witnessing waves of different viruses. So, I'm sure our colleagues know that, after COVID, particularly when COVID started declining, we witnessed viral infections in the form of RSV, adenovirus. In areas where measles vaccination was on the lower side, we witnessed outbreaks of measles. We also had hand, foot, mouth disease. All these basically are viral illnesses. One more thing is that we have been giving vaccines to children, and mostly these are vaccines against the bacterial respiratory infections. Let us take the example of, say, pneumonia or maybe Haemophilus influenzae. So, all these they are the bacteria, and we have plenty of vaccines against bacterial respiratory infections. But viral respiratory infections usually are the ones which predominate because of paucity of vaccines against, say, RSV or some other viruses like adenovirus and so on and so forth. So the immune debt which was seen in the post-COVID period was responsible for upsurge of these viral illnesses, and that's why we have been observing recurrent respiratory infections. We are also witnessing otitis media, adenoidal hypertrophy, unseasonal surge in influenza. Usually, influenza is a disease related to monsoon, and these days we see that influenza is seen even all around the year. Okay, we have also witnessed adenoviral outbreak, and I always say that adenovirus has become a bad adenovirus because it shows varied presentation and prolonged illness, and we have diagnostic dilemmas because many times in adenovirus we have rise in the complete blood count, rise in the CRP, and so on and so forth. What we have to remember is that when a child comes for cough, cold, fever, and progressive breathlessness for 3 days, just as this child was brought to the hospital with tachypnea and hypoxia, wherein we noticed that this child had X-ray picture suggestive of ARDS. One has to be very, very careful because when you admit such a child into the PICU, ventilate the child, and the child receives oseltamivir along with supportive treatment, and when it turns positive for H3N2, when you take the nasopharyngeal swab, you ventilate the child for 3 days and the child improves, one always starts thinking whether early oseltamivir therapy would have helped this particular child. Okay, so initially, quite a few children are healthy. They present with cough, cold, and fever. They progress over 3 days, and then the treating clinician can prevent the progression by giving oseltamivir upfront, particularly in the flu season. There are situations where a pediatrician gets confused, and as these are the points related to flu, I have put it as confusion. So the confusion is basically whether this respiratory infection is bacterial or viral. If it is viral, what is the virus? Whether it is rhinovirus, adenovirus, influenza, or parainfluenza. If it is influenza, whether this is H1N1 or H3N2, and then whether I should start oseltamivir upfront. So there are various questions in the mind of a practicing pediatrician. Let us see what happens in a typical OPD. The child is brought with fever, cold, and cough. Usually, the pediatrician examines the child, and some of these children who are obviously, appearing clinically as viral, they leave the chamber receiving paracetamol and some antihistaminics. Those who are having high fever, they, probably are given antibiotics and they go home. But then nobody asks the parents to come for a follow-up because influenza is a biphasic illness, and day 3, 4, 5, the child can worsen. So it is very important that when you instruct the parents about the medicines, please tell them to come back for follow-up after 4 or 5 days. In my practice, I never charge the parents for their follow-up. I never collect the follow-up charges. So I tell the parents that you come after 4 or 5 days, you will not be required to pay because our parents, our patients, they are poor patients, and every time, for them to pay the consultation charges is not possible. So when they are assured that we will get a free follow-up, then they come. When they come, you are learning. So I always take it as, as if, this free treatment, is the tuition fee that I am giving back to the, patients, because they are teaching me. The teachers are the patients. Our best teachers are our patients, isn't it? So you have to remember that you have to follow them up, because these children, if they have started worsening, then you can pick them up early and start oseltamivir on time. This is very important. Now, as we are all aware, there are different illnesses in monsoon, like the influenza-like illness. Though, remember that influenza is the father of all those influenza-like illnesses, and I will tell you why I call it so. The incidence of influenza and the related deaths has been increasing alarmingly in India. And one must be aware that the KYC of this particular naughty influenza virus is very interesting. Okay, so you must know your customer. And influenza A is the one which causes frequent epidemics. I told you that there are some minor antigenic variations, which I told you in the beginning, that is a drift. Okay, and periodic pandemics are also related to influenza A. There are some 18 types of influenza A H antigen and 11 types of influenza A N antigen. I will tell you more about these antigens, and combinations of these H and N will produce a different kind of a virus. So it would be H1N1, H3N2, H2N2, whatever it is. So one H and one N together makes an influenza virus. Influenza B infects only human beings and causes local epidemics. This particular virus doesn't, infect the animals. It's seen only in human beings. That's why pandemics or large epidemics are not usually seen by influenza B virus. In case of influenza A, the virus infects the birds and the human beings. So the virus from the bird, virus from the human beings, they mix up together in some third animal like a pig, and the pig acts as a mixing vessel, and a new virus generates in the pigs. Okay, and that's why that new virus is the one against which the human beings do not have any immunity, and that results in the pandemic. And of course, as I was trying to tell you about the two glycoproteins which are present on the outer side of influenza virus, there are HA and Na. HA is the hemagglutinin and Na is the neuraminidase. So HA basically is the molecular key. What I mean by molecular key is that hemagglutinin is the glycoprotein with which this influenza virus gets itself attached, okay, to the respiratory epithelial cell. And the RNA of this enters into the respiratory epithelial cell. There it multiplies. So, many copies of this RNA are produced. You know that viruses are totally dependent for their survival on the other cells. Okay. So, inside the respiratory epithelial cell, so many copies of RNA are produced. And now these copies are ready to get out of the respiratory epithelial cell to infect other cells. Okay. And for this, it is necessary that these virions are separated from each other by a scissors. Okay, so this neuraminidase is a molecular scissor. Okay, it helps in literally cutting off these different virions and releasing them into the respiratory from outside the respiratory epithelial cell. However, oseltamivir is the molecule which is a neuraminidase inhibitor. So that is the place where that particular molecule acts and stops the release of the virions from the respiratory epithelial cell to other respiratory epithelial cells. And that is why when you give it early in the course of illness, the spread of illness is prevented. So that is the basis for the use of oseltamivir, which we are going to see in further details in the due course of our lecture. Okay. There are four major global pandemics which have been described in literature as relates influenza. The first one was Spanish influenza 1918-19, where almost one third of the global population was involved. There was no oseltamivir at that time, and all the children and the adults who got serious, they were treated only conservatively. Okay, so it was a major global pandemic, H1N1. Then there was 1957, 1967, and then, of course, 2009, when there was a pandemic, which most of us have witnessed. That was again H1N1. Okay. And the most important thing is, in the current situation, in most of the parts of our country, H3N2 is the strain of influenza which is circulating and affecting the pediatric population. One must be aware that the vaccine which we give to children has H1N1, H3N2, and Victoria and Yamagata lineages of the type B. Okay. And there has been, a change in the recommendations given by WHO. And, this type B, one of the strains, is not going to be included in the vaccine, though there are different opinions about this exclusion of one of the strains from the vaccine, which is, of course, not a part of today's discussion. But one should be aware that, these viruses like influenza, many times they are seen in upsurge when another major epidemic or a pandemic is on decline. For example, when COVID pandemic started declining, influenza started appearing, in different parts of the world. Till COVID was going on, influenza was quiet. It did not say anything. But later on, it started coming up. So all these strains, they show a lot of variation every year. But one should remember that it is prudent and wise to remember as to what is the type of the circulating strain. And as of now, H3N2 is a major strain, though we see all those different types like H1N1 and B also in different parts of our country. Okay. What you should remember is that this virus can spread to others up to about 6 feet, and the main spread is by droplets when a person coughs or sneezes, and these viruses, they land in the mouth or the nose of the people who are nearby, and then they are inhaled into the lungs, and it's a highly transmissible disease. That's why we recommend use of the mask and keeping a social distance of, a hand's distance, and this is very important, so that, the medical fraternity is very important, because children directly cough on our faces, and we have to take a proper care. So every day in the OPD, in the morning, evening, whenever you go, please see that you wear a mask. Otherwise, your 3 days, your 5 days, depending on, the illness that you get, are lost. You feel weak, and then prostrated. You have to take rest. You don't have the energy, and why to unnecessarily suffer? Okay. So patients should not, give you the illness. Okay. And that's why you must wear a mask and follow all these precautions that, we have been discussing for so many years now. Okay. So there are different clinical scenarios with which influenza typically presents. I told you that influenza is the father of all the influenza like illnesses, meaning thereby it will have the major presentations of a systemic disease like headache, high fever, fever with chills. It will have malaise, weakness, myalgia, muscle pain, and headache. All these are the symptoms. And I have seen so many parents literally lifting even an older child, about 8 or 9 or 10-year-old, and bringing to the clinic. Why? Because there is a lot of weakness. Okay. So I always call influenza as the father of influenza like illnesses. And why I want to stress this is because it is eminently treatable. And that's why this illness, that is morbidity, the absenteeism from the school, from the work, all can be prevented by the early use of oseltamivir in particular situations. Of course, we have seen different presentations of flu apart from the typical presentation in the form of febrile convulsions, okay, encephalopathy, myocarditis, and gastrointestinal symptoms. Remember, viral infections and bacterial infections are different. Influenza is a virus. So what will it do? It will affect more than one system in a child. So it will affect respiratory as well as GI. So the same child who has respiratory symptoms will have vomiting and diarrhea. It will affect more than one member in the family. For example, if I am involved, I might transmit the infection to my father, my mother, my wife, my children. So in a family, there will be more than one member. And within the community, there will be more than one families. So typically a viral infection will have more than one system in the child, more than one member in the family, and more than one family in the community. This is typically viral, and these points you must ask in the history. Okay. And remember, that different respiratory viruses have their own presentations and a few points which would differentiate them from others. For example, for COVID, we knew that loss of smell and the loss of taste were one of the important features. Okay, for rhinovirus, we know that the presentation is not that severe, so on and so forth. So, what is important is that you know the warning signs, emergency warning signs of flu illness. So, whenever a child of influenza, basically being a respiratory virus, one has to be clear that the progression is going to occur to the lungs and ultimately the child is going to have pneumonia. Okay, so the child with pneumonia will have fast breathing. If there is hypoxia and the child worsens, he will have cyanosis. Because of the illness, he won't have enough fluids. He would stop interacting because of hypoxia, and hypoxia will also make him irritable. So he doesn't want to be held. And all these are the warning signs, emergency warning signs. So when parents come to you, tell them that if anything of these happens, please come back, because these symptoms are the ones where you might be required to admit the child in the hospital. There are some complications of flu, like pneumonia and ARDS. They are related to the acute respiratory infections, that is A. So there are different A's related to the complications, like acute otitis media. These viruses, they set a stage for secondary bacterial infection. Okay, and of course, primarily also they produce acute otitis media. Of course, as I told you, children will lose their school, leading to absenteeism from the school, and amdani is the income of the parents, that also will be lost because they are at home, and the confusion whether it is viral or bacterial many times leads to antibiotic abuse by our colleagues. So remember, influenza is not a simple disease, and it is important that you know that there are three categories of this particular disease, like A, B, and C. So in the category A, which is an uncomplicated or a mild illness, the patients come with mild fever, cough, and a sore throat, uh, maybe with body ache, but then usually they have body ache, headache, and some of them, as I said, could have diarrhea or vomiting. But in general, it is a mild illness. Okay, and when there is monsoon season and when the epidemic situation is around, you should be aware that this is likely to be influenza. You are not much worried. Here, you have to inform them about the emergency warning signs. And in case if the child or the adult presents to you and comes with high grade fever, okay, severe sore throat, in addition to the fever, cough, and cold, which you have noticed in category A, then these are the ones who need to be rather advised about rest, isolation at home, and these are the ones who will require oseltamivir. Okay, this also includes individuals at a high risk. So there are children, particularly who are under the age of 2 years. Then in the family, it could be that not only the child, but there are some high risk individuals like the pregnant women, the grandparents who are above 65, or there are individuals with chronic health issues related to the lung, heart, liver, or kidney, or diabetics, or neurologically involved, so on and so forth. So these are the patients who are called as high risk individuals. There could be some on steroid therapy, like nephrotic syndrome and so on and so forth. So these are the ones which also require oseltamivir. And in category C, where it's a severe disease, where the respiratory rate is high, but also there is breathlessness, hypoxia, chest pain, the blood pressure is going down, okay, so on and so forth. There is cyanosis and excessive sleepiness, and all those emergency signs that I told you, and those who find it difficult to breathe. So these are definitely the ones who are to be hospitalized. There you have to try and get the diagnosis by doing a nasopharyngeal swab and put the child on oseltamivir. So this will really help you. This categorization will help you to use the medications on time. And particularly, as I told you, the nasopharyngeal swab facility, if at all it is available in your city or town, well and good. But if not, these important symptoms and signs will at least guide you to the early use of oseltamivir. Now, when we are speaking so much about oseltamivir, let us know a bit more about this molecule. As I told you, it's a viral neuraminidase inhibitor, and that's the prodrug, which is converted into the active form oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and further spread of infection. Okay, and this was the first oral neuraminidase inhibitor which has been approved in more than 100 countries now, and CDC and American Academy of Pediatrics have approved this particular molecule. And as I told you, the categories of treatment A, B, and C include, just to revise, category A therapy involves home isolation, bed rest, plenty of fluids, and paracetamol for fever. Never give aspirin because aspirin is associated with Reye syndrome. Okay. And category B requires all these, which we use as a mode of therapy for type A along with antivirals, and testing may be done. And in category C, the testing, hospital admission, and use of oseltamivir along with supportive therapy are required. It is important that our colleagues are aware of the dosage and the recommendations of oseltamivir. So adults require 75 milligrams twice daily as a part of therapy, and 75 milligrams once daily as a part of chemoprophylaxis. And in children, the therapeutic dose is given twice daily, and it depends on the weight bands from 15 kg up to above 40 kg. You can just remember the various dosages. In fact, you can keep the dosage in front of you so that you can calculate easily. But for chemoprophylaxis, you have to use once daily dose. The therapy is given for 5 days. Chemoprophylaxis is given for 10 days. Why longer therapy for chemoprophylaxis? Because the virus continues to be thrown out from the respiratory secretions, cough, and sneezing, even after the fever disappears. Okay, that's why you must give chemoprophylaxis a little longer. And under the age of 1 year, you have to give the dose of 3 mg per kg twice daily, and under the age of 1, chemoprophylaxis does not apply. Now, when you start oseltamivir early, it is important to note that the child, the progression of the illness is reduced, the duration of the illness is reduced, and the child doesn't progress to severe disease. Now, once you know the mechanism, which I already explained to you in the earlier part of my talk, that it blocks the release of the virions from the respiratory epithelial cell to the other cells. So when you start early, all these obviously are the advantages. Okay, so the duration of illness will be reduced, the progression to severity will be reduced, complications, which I told you, will be reduced. And that's why even if a child comes late on day 4 or 5 and gets admitted with low respiratory infection, with distress, and tests positive for influenza, you are absolutely justified in starting with this particular molecule, because it will further stop the spread of the infection from within the child, that is from one respiratory epithelial cell to other. Whatever disease has occurred, it will be halted, it will be arrested at whatever stage it is. And at some of the institutes in my city, there have been different clinical trials where we have found that oseltamivir works wonders even when given late in the course of the illness. Okay, and that's why many clinical trials have shown that it reduces the antibiotic use, the influenza related low respiratory tract complications, and hospitalizations, not only in children, but also in adults. Okay. And that is why you have to remember to start oseltamivir empirically in the initial part of the illness. And WHO has recommended, strongly recommended empiric therapy. WHO says that treatment should be started as soon as possible, and lab confirmation is not necessary. Remember, the virus of influenza, if it is seen on the nasopharyngeal swab, if you get a report positive, then it is almost 95% that this child has influenza. It is really uncommon that the child has influenza and the test comes negative. You get what I'm saying? So it is only, if you do not take the swab properly, or if the technique is wrong, then of course the influenza virus may not be detected. So in general, considering all these situations, the positivity rate in certain areas comes to about 70%. However, in a properly done nasopharyngeal swab, or a properly taken nasopharyngeal swab, usually if the child has influenza or if the adult has influenza, it usually comes positive. Okay. And that is why start oseltamivir early, give supportive therapy, and monitor this particular child. Okay. There are some cases which I would just like to explain so that you understand the topic further clearly. So there is a child, I have named him Viru because it is a viral illness, of course. And he has fever for 3 days with cold cough and has been on metered dose inhaler. He has been well controlled and he has again come, with fever and cold. He was active in between, but now this respiratory infection has recurred. You will agree with me that such, children, such types of children, they are very common in the OPD. Once the respiratory infection is controlled, within a short time they will again come. Okay. And the dilemma is whether you should give antibiotic or not to give antibiotic. This is very important. One has to look at the clinical picture. I told you, if the symptoms are mild, if the onset is with cold, remember when your onset is with cold, okay? So just explain to the parents that the onset is with cold, so it is viral. Even though it has recurred, it is viral. And viral infections, we do not give antibiotics. Okay. Tell them that these are the emergency warning signs. Observe this child. Come back to me after 4 or 5 days. If the fever worsens, if the child becomes very weak, if the child starts getting, headache, or you really feel that the child is unwell and developing breathlessness, please come back. I will examine and then decide what therapy is to be given. Okay. You have to counsel the parents. Tell them that respiratory infections of viral nature occur about 8 to 10 times in a year. But the growth chart is important. You have to maintain the chart which shows progressively the child is growing well. The weight is increasing from 8 kg to 9 kg to 10 kg over a period of 6 or 12 months. And that is the indicator that the child doesn't have any underlying problem. Okay. And tell them that this cold and cough and all these viral infections are the members of your family. Okay. So they are the members. So as the child is growing, these members will be there, so you need not be worried about it. And provided the child is doing well, you don't worry. But you have to take a extra time, to counsel the parents. These days what happens is, the parents also don't have time and the doctors also don't have time, and that's why many times, it ends up, a short discussion where, parents get paracetamol, antihistaminics, and maybe antibiotics, and the child simply leaves the clinic in a very short time. This should not happen. If you don't have time, please involve the receptionist, or you can appoint someone who can speak to the parents. Majority of the parents, they'll be happy if you speak to them for a longer time. If you don't have time, as I told you, employ someone who would explain. These are very simple things. But then, in case if you want something to be conveyed, they have to be told to the parents. We many times assume, अरे ये क्या parents को मालूम होगा, ये बताने की क्या जरूरत है. This is not so. It is important that you tell them that these are the facts, because it is possible that the parents do not know what you know, and whatever I am telling you today, please see that it is translated in the language of the parents. I'm sure many of you are not practicing in a very hi-fi situation where swabs are available, and things like blood gases are available at the tip of the finger. No, I am aware, fully aware, and that's why ignorance, which is the main enemy of our patients, has to be kept at the back of mind. So explain to them. And these days I am sure, even in my practice, many mothers who come, they go to the school. Many of them are those who have completed 9th or 10th or 11th standard. They get married at an early age, I understand, but their understanding level definitely has improved over last 10 or 20 years. So they will understand. So try to counsel them in your own language, in your own way, whether it's in your own Hindi or any language which is spoken locally at your end. Okay. You should be aware that there are certain indicators of, viral illnesses. For example, rhinovirus. It will be basically, a mild illness with common cold. The child will not be exhausted and the child will be playful. I told you that flu is the one where there is prominent headache, myalgia, extreme weakness. Adenovirus is a different story where you get pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, hemorrhagic cystitis. And viruses like RSV will produce bronchiolitis, okay? Usually affects children under the age of 1 year. And bacteria like group A beta hemolytic streptococcus produces fever, follicular tonsillitis, and tender cervical nodes. If it's pneumococcus, it will produce pneumonia, which will come with fever and grunting. And staphylococcus, the child will have rapid progression of the illness. Mycoplasma usually will affect older children and predominantly come with cough. Okay, this was a child who again came for cough and fever, was not settling with oral medicines, and required oxygen support as he was tachypnic. And you can see that there is involvement of the right side of the lungs on the X-ray, and the WBC count was on the lower side. Platelets were also on the lower side. We investigated the child even for dengue, but the tests were negative, and liver functions, of course, were deranged. I told you, viral infections will always infect all the organs. Okay, so the liver is involved, so the SGPT, SGFT are on the higher side. Okay, the bone marrow is suppressed, so the counts are on the lower side. Okay, the swab showed H3N2 positivity, and this particular child was put on oseltamivir. Another child who came with similar presentation and also was having H3N2. I'm just telling you and showing you the X-rays which we witnessed in our hospital, so that you are aware as to what are the various clinical presentations. This child was again a case of H3N2 influenza, but here the counts were normal, but the CRP was on the higher side. Okay, and one should remember that earlier you start oseltamivir, it is always better. Okay, of course, one of these children, it deceived. This child, turned out to be positive for adenovirus. Of course, we had a suspicion when the WBC count was on the higher side and the CRP was also on the higher side. Remember, adenovirus is the one where it doesn't follow the rules, okay? And I told you in the beginning that adenovirus has turned into a bad adenovirus, okay? So you have to be very, very careful, okay? There are sometimes, children like this girl, 5-year-old, who came for high fever, cough, cold, and appeared sick, and the child had mild wheeze, but there were no crepitations. Okay. And now this child was given amoxiclav. The counts were on the lower side, and in view of these lower counts and the season of influenza, we put the child on oseltamivir. But the swab did not show influenza. In fact, it showed rhinovirus. Okay, so one should know that when you feel clinically that this is influenza, start oseltamivir. Okay. So the swab, as I told you earlier, may not come positive for influenza. Maybe some other virus is seen, but they are called as innocent bystanders. Okay. They are simply present. Just as, whenever there is some accident, there are always onlookers. They are not important people. Okay. The most important is the person who is involved in that particular accident. Okay. So who is creating the problem? So influenza is creating problem, but what has happened is the other people, when you test the nasopharyngeal swab, rhinovirus and other minor viruses, they may be detected on the nasopharyngeal swab. So go from your clinical judgment. Do not give much importance to these viruses, because rhinovirus, is not something very great and which is going to create such a great problem. Okay. So continue with oseltamivir, and you should know, as I already told you, the sensitivity of influenza PCR is very good. Okay, I told you, if you find it on the nasopharyngeal swab, 90-95% that it is, yes, it is influenza. Okay, and then you can take your treatment decisions accordingly. Most important thing is, when certain parents from the IT sector, now in the areas like Pune and Bangalore, where lot many IT, information technology parents are there, they are always very, very anxious. They say, sir, ये बच्चे की एग्जाम है, 2 दिन में अभी एग्जाम है, आप कुछ तो कीजिए, गिव समथिंग. They always will pressurize you. You have to be very clear, and you have to go as per your conscience. Tell them the throat is only mildly congested, and even though fever is on the higher side, observe the child for 1 or 2 more days. Okay, and even though the flu and the adenoviral infections are going on, there is no harm in waiting for a while. Only if the child has worsening of the symptoms, then I will try and give you, certain antibiotics or antivirals depending on the clinical situation. These are tricky situations. Many times, our colleagues, they have to, or rather, they do listen to these parents. So many times, they advise investigations, they advise throat swab, they start empiric oseltamivir. All these are individual decisions depending on the clinical presentation and also, the examination finding. If you really find that the throat, yes, there is irritation of throat, but there are follicles on the tonsil. Yes, there are tender cervical nodes. You are justified in starting antibiotics. Okay. If there is a lot of influenza around, if there is someone in the family who has influenza and this child has very high fever, yes, you can put this child on oseltamivir. However, you have to be very, very clear when these situations are tricky, and you have to take your individual decisions. Okay. Remember, there are certain children who really require antibiotics like coamoxiclav, and you do get such children who have high fever, crepitations, and persistent fever, and you put these children on amoxiclav, and the throat swab comes positive, and then you are, thinking whether I should stop the antibiotic which I started, because now the influenza investigation has come positive. What do I do? So again, decision depends on whether this particular child is, showing certain symptoms related to bacterial infection. It may happen that this child has secondary bacterial infection. Remember that 25% children with influenza, they do have additional infection with either Streptococcus pneumoniae or Staphylococcus, and that's why some children, they do require antibiotics. But in case if you find no, that this child otherwise the investigations are, like WBC count of 7,000 and CRP of 2.8, usually we don't suspect bacterial, isn't it? So we may continue oseltamivir and we may stop the antibiotic. But if the child continues to be toxic, very sick, and if the child has some other clinical features suggestive of bacterial infection, then you can continue with antibiotics. Okay. So that is the place where your experience counts. That is the place where your examination counts. And that is why please take adequate time for history taking, for examination. Very important. Give some time. I will tell you, the poorest of the poor patient will understand whether, you have examined the child properly or no. I have heard so many parents in front of you, they don't speak anything. But as they go outside, in the waiting room, they say, अरे डॉक्टर साहब ने हाथ भी नहीं लगाया, सिर्फ बोले गला दिखाओ, टॉर्च डाला अंदर और दवाइयां लिख के दी और मुझे भगा दिया. So that is what people say. That should not happen, because, examination and approach, that is the real purpose for which we are in this medical field. If we start being casual and not examining patients properly, what is the purpose of our life, isn't it? So please see that you are very serious when you examine and take the rational decisions. Okay. And whatever I discussed just now is a part of what is called antibiotic stewardship. Steward means rakhwala. Rakhwala, is a person who decides, just as, you must have seen so many stewards, like, very tall people, standing outside a five-star hotel. They allow some people inside and they do not allow some people inside, okay, to enter into the hotel. Similarly, conditions where you allow the use of antibiotics and conditions where you don't allow the use of antibiotics. For example, very mild fever, very mild cold, cough, no antibiotics. Then bronchiolitis, usually no antibiotics. Fever with urine showing only 2 or 3 pus cells, no antibiotics. But as I told you, some conditions you need to give antibiotics. For example, bloody diarrhea. For example, child with follicular tonsillitis with tender nodes. Okay, so these are the situations where you should be very, very clear about different aspects of the clinical approach. Okay, there have been cases which have shown some neurologic involvement of influenza in the form of febrile convulsion and influenza-associated encephalopathy, acute necrotizing encephalitis, and these have been managed in the intensive care settings. One must be aware that influenza can have neurological problems. Influenza also can come along with RSV. Influenza can also come with respiratory complications, which I told you earlier. And influenza can also come with toxic shock syndrome, myocarditis, myositis, which produces severe calf pain, particularly in influenza B. and these children, they are unable to walk. This is because of the involvement of the gastrocnemius and the soleus muscles. Okay, and then as I told you, children who are having influenza B, when they are exposed to salicylates, can have involvement of the liver, something akin to liver failure, producing what is called as Rye syndrome. As a part of some queries which usually come in the minds of our colleagues, one should remember that if there is an older child in the family who has tested positive for influenza A or B, and then, in the same family, if a younger child develops fever, what do we do? Obviously, 8 months is a high risk category. I already told you that under the age of 2 is a high risk category, and already there is a contact in the family. And that's why you are justified in starting oseltamivir for the younger SIB. Okay. Remember that in general, children do not throw out, oseltamivir. So you have to use your tactics to see that the child receives either the oral syrup formulation or maybe a capsule in an older child. But there is no alternative. You have to give that. Okay. And if there are high risk contacts in the family, you have to see that they receive chemoprophylaxis. As I told you, there could be a diabetic father, a pregnant mother, an asthmatic grandfather, or someone on steroid therapy. Okay, so you should treat them prophylactically with oseltamivir. And remember, if the throat swab report shows parainfluenza, oseltamivir really doesn't work on the parainfluenza viruses. That's only for your additional information. So remember, my dear friends, that influenza is a fast and a furious virus with an abrupt onset, with a high transmissibility, rapid progression to complications like ARDS, and that's why you also have to be quite fast in using oseltamivir fast within 48 hours. Okay, as I told you, sanitization, mask, and social distancing were the rule right from our influenza pandemic, even during COVID pandemic. We have been following cough etiquettes, which need to be continued, like coughing in the elbow. Okay, and using Hasta Pancha Sutri, the 5 sutras related to the hand, like frequent hand washing, avoiding the handshake, use of a handkerchief, keeping others at a hand's distance, and avoiding hand touching. Okay, and also taking flu vaccine every birthday. Remember, flu vaccine is to be given only once in a year. Okay, and that's why I always say, along with happy birthday to you, always remember the slogan happy birthday to flu. Okay, so on your happy birthday, in addition to cutting the cake or having a party in some good restaurant, see that you also get a prick of flu vaccine and protect yourself, because in our clinic, in our dispensary, we are the ones who are most likely to get influenza. So see that your staff members also receive this flu vaccine. With that, I bid farewell, and I say namaste. And of course, being a virtual meeting, I will not be able to shake hands with any one of you, but at least today I will just send a message that salute the other person with namaste and avoid handshake. With that, thank you, and I stop sharing and hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. Thank you very much. Thanks for all those insights, especially the handshaking and avoiding of handshaking. Thanks so much. Thanks all the doctors who took time from the scheduled and attended this meeting. Thank you, Nagadevi, and thanks, Srinivas. Thank you, sir. We can sign off, sir. Thank you. Wish you
Thank
very good
you.
afternoon. Thank you.